Good evening, ladies and gentlemen. Hearty welcome to the 43rd session in our Learn from the Legends International Webinar Series in Neonatology, organized by NNF Kerala and IAP Neonatology Chapter. It's indeed an honor to have Professor Anne Hellström, Professor of Pediatric Ophthalmology, Sahlgrenska Academy, Sweden, who will speak to us on advances in the management of retinopathy of prematurity. This session will be moderated by Air Commodore Samsher Singh Dalal, Professor, Armed Forces Medical College, Pune, and Professor L.S. Deshmukh, GMC Aurangabad. Once again, a warm welcome to the eminent faculty and all participants. Thank you very much. Over to Dr. Manoj VC.
Hello everyone, hearty welcome. Today we have Professor Anne Hellström, an outstanding researcher in the field of pediatric ophthalmology, to deliver the 43rd lecture in our international webinar series. Professor Hellström, as we all know, is world famous for a work on retinopathy of prematurity, a leading cause of childhood blindness. She has approached the research field of ROP using several techniques. That's remarkable. Developing innovative and reliable tools to optimize the prediction of infants at risk, demonstrating important mechanisms of pathogenesis, discovering new innovative therapies to prevent ROP, and evaluating these in clinical trials. Since 1987, Professor Hellström has been passionate in research and has published over 200 papers in international scientific journals and has an H index of 57 with over 12,500 citations. As some of us know already, she, in a landmark paper together with Professor Lois Smith, published in PNAS in 2001, showed in a mouse model that low IGF-1 suppressed VEGF survival signaling in retinal endothelial cells, and went on therefore to show that this was directly correlated with the development of clinical ROP. These early results, we all know, paved the way for a series of important papers in this century, confirming that IGF-1 is critical for normal vascularization of the retina and that IGF-1 deficiency is associated with ROP both in animals and humans, and the IGF-BP3 prevents ROP development. And actually, friends, that is the reason why we decided we should request her valuable time here and have her somehow in our series. And today we have the legend with us. Friends, we all know in the subsequent years post this discovery, Professor Hellström has also shown that the poor early growth of preterm infants reflecting low IGF-1 levels is a strong predictor of ROP risk. This actually led to clinical trials evaluating the possibility of using IGF-1 replacement therapy to prevent ROP development in preterm infants. Professor Hellström has published the first report on pharmacokinetics of IGF-1, IGF-BP3 treatment in preterm infants, and this treatment is currently evaluated, we all know, in a large international multicenter trial we all caught here and there. Let me take the liberty to elaborate a few more inventions of her. It's too many. I'll just summarize in few words. I don't want to stand between you and the legend. After discovering the connection between IGF-1 growth and ROP, Professor Hellström also started to investigate the role of early nutrition on ROP development in preterm infants. In a seminal paper from 2007, together with again the same legend, Professor Lois Smith, she showed that omega-3 PUFA suppressed retinopathy, and she established the specific metabolites affecting the suppression. This has prompted two Swedish multicenter trials, if I am not mistaken, investigating the effects of different intakes of omega-6 and 3 PUFA, including DHA and ARA, with very promising outcomes on ROP, which we will hear from her today. Friends, These are only examples of the scope and impact of Professor Hellström's research contributions. His studies are a perfect example of collaborative, together with Professor Lois Smith, translational bench to bedside research, translational research using discoveries made in experimental models to develop treatments implemented in clinical practice. That's what we all want. The actual research results have generated several patents, I'm sure, including computer algorithms for predicting ROP development, something I hope she will enlighten us today. Professor Hellström has received numerous awards, including the Athena Award in 2012, a prestigious recognition of leading to clinical implementations. In 2012, she received European Union funding of 6 million euros for the project Prevent ROP. And we all know in 2019 she received Wallenberg Clinical Scholars, an extremely prestigious program that provides funding over 10 years for some of the country's most foremost clinical researchers in Sweden. Professor Hellström is not only a world-leading researcher in ophthalmology. Why we know her? Because her research on preterm infants has also made her a leading researcher in neonatology. Her research has led to improvements in the care of preterm infants, and ongoing clinical trials are evaluating the further clinical benefits of clinical treatments. ROP, we all know, is a significant cause of childhood blindness, especially with the new smaller and smaller preemies, ridiculously low birth weight babies surviving. And because the survival rates of extremely premature infants are improving, the frequency of this devastating condition also is increasing, especially with the survival of this, to borrow Professor Martin Kessler's words, ridiculously low birth weight infants. Professor Hellström's research has had a very significant impact in the field, as she has been a leading contributor to various things like development of new tools and guidelines for clinical optimization, important advances in our understanding of pathophysiology, and clinical trials evaluating the effects of possible agents to prevent ROP. Friends, I can go on and on. That probably I would not be doing justice to the time we spent together. I am sure that all of us know she is a true legend in this field, and we are so fortunate to have you, madam, with us. Professor Hellström, thank you so much. Over to you, madam.
Thank you very much. Thank you so much for inviting me to give this presentation on advances in the management of ROP. It is a true honor to be among the legends that have spoken before me. So, as a pediatric ophthalmologist, this is what we do at the university clinics approximately twice a week. We examine the babies for looking how the vasculature develops in the retina. Before the invention of the retinal photography, we used indirect ophthalmoscopy as this. By giving a dilating drop using a magnifying glass, we could see how the vessels grew from the back of the eye towards the lens. And in approximately 70% of the babies, it looked like this, what we see here, where you can see that the vessels grow perfectly normal from the optic disc towards the periphery. However, in about 30% of the babies, we see this. We can see an abnormal retinal vascularization, where we can identify the unvascularized retina and the vascular part of the retina. In another approximately 7 to 10%, we have to treat the babies. This is a baby with aggressive ROP that was very heavily treated with laser. And every yellow spot you see here is a laser burn on the retina. And as you can understand, this is a destructive treatment, but it saves the child from becoming blind. And of course, this baby will have a reduced visual field. And as we heard, ROP is still one of the main causes for childhood blindness. And approximately 20,000 babies become blind every year because of ROP. In Sweden, we have now, since over 10 years, had a national patient registry where every baby screened for ROP is collected. We have now more than 12,000 babies. And by doing that, we now know about the natural history of this disease. And as I mentioned, about 70% of the babies do never get any ROP. And about 30% do get some stage of ROP. And in Sweden, approximately 6 to 7% are treated. This figure varies dependent on the neonatal care the baby perceives. But as we also heard, we now save, or you as neonatologists, you save younger and more immature babies. And that results in more babies that get the severe disease that needs treatment. We have shown this in Sweden, and it has also been shown in other parts of the world where neonatology care is at its forefront. So why are we so interested in ROP? Why is ROP important for neonatologists? Well, I think most of you are aware that ROP is one of the strongest biomarkers for later outcome in these babies, especially neurocognitive and neuropsychiatric outcome. And that is not so strange as the retina is part of the brain. And by looking how the vessels grow on the retina, we can actually also follow how the brain grows. So this leads to the first question I have. What about ROP and its pathophysiology? Is it a vascular disease, a neural disease, or a neurovascular disease? Please vote. So you are all very well trained because as seen, it is a neurovascular disease. Before it was mostly considered a vascular disease, but it is absolutely a neurovascular disease. Can we move on? It seems as I cannot scroll on after this.
Is it, ma'am? Let me just. You are not able to. Please try
No.
now. Yeah.
No. It won't move forward now.
1 second, ma'am. Just.
Yeah.
Can you try now, ma'am?
No, nothing happens.
I think that must have got frozen at that point, ma'am. Can you just stop sharing and again start sharing, ma'am? Because there is something I'm not able to do from here.
Okay, so I stop sharing and I come back.
Please again start sharing, ma'am.
So, yeah, thank you. And now it works. So actually it is a neurovascular disease, and by defining that, it was found from histological studies that on the border between the vascular and unvascular area, it was actually the astrocyte precursors who produced VEGF and contributed to the pathological neovascularization. So as it is a neurovascular disease, and we know that the preterm babies have microstructural changes in the brains, not only focal brain lesions like intraventricular hemorrhage, but we know by today that they have an also abnormal brain configuration. So at our university, we have unique possibilities to study a brain injury biomarker in very, very small volumes. And by doing that, we wanted to study the brain biomarker neurofilament light that has been shown in for instance, boxers and in people that have been out in space to be much higher than in a normal population. And you can see the green line, dotted line in the bottom of this figure, which corresponds to values below that is normal levels in adults. And we found in the preterm babies that the levels of this brain biomarker was severely increased during the first month of life. And looking at different neonatal variables to see what was correlated to this increase, we found, in fact, that the only factor of morbidity factor and nutritional factor was ROP. So if the babies had any kind of ROP, which is the red dotted line here, we found that the babies had increased levels of this brain injury biomarker. And in fact, it was, of course, the most immature babies that had the highest levels, but even after adjusting for gestational age, the finding was still persistent. So for sure, looking at how the vessels grow on the retina, we can get a picture of how the brain is doing in the corresponding baby. Everyone, when it comes to prevention, knows that oxygen is a main player, key player. And of course, delivering uncontrolled oxygen levels, even at more mature levels of the babies, they can get ROP, as we have seen in several countries. When the large BOOST study was published, many neonatal units increased their target ranges, as did we in Sweden. And after doing that, we found a 50% increase in the most severe forms of ROP. So we were interested in finding out why these babies actually developed, what components of oxygen were responsible for this increase. So we looked at almost 2,000 babies, which had very high resolution data. And we actually found that it was in the babies that had severe ROP, they had actually lower mean oxygenation, but they had a much higher variability. And this has also been shown by others, that it is actually the variability that is the crucial factor. And of course, if you have a very immature and sick baby, it's more difficult to keep it on a higher target range, and thereby the baby usually have a bigger variability of oxygen saturation. Today in Sweden and in many units, there is one standard for oxygen targets and oxygen delivery, independent of gestational age, of postmenstrual age, of sex, of if the baby has anemia or not, and of also regarding the proportion of fetal hemoglobin. And I believe in the future that this is a perfect area for personalized medicine, because all these factors we know contribute to how the baby is oxygenated. So I think there is a large improvement to be made here, but unfortunately, large randomized trials looking at these entities does not exist today, but it is really, really wanted. One factor that we know plays a role in oxygenation is, as I said, the blood components. So this brings me to the next question. We'll see if this works. Looking at risk factors for ROP, do you believe that it is the number of blood transfusions that is the main risk factor, or is it the cause of transfusions, namely the anemia? So time to make a vote again. Okay, so I'm happy I can contribute a bit here because actually looking at the literature, it is most of the time stated that it is the number of blood transfusions. However, I do not believe that is correct. It is rather the reason for blood transfusions, namely the early anemia. I think I have to stop share again and go back because it doesn't want to work with me now. Okay, so we did show a couple of years ago that looking at try to titrate out which was the most important, we found that very early anemia was the most prominent risk factor rather than the transfusions itself. And it is interesting that it is this early anemia that actually is associated with a retinal abnormal vascularizations months after this early low anemia. And we did a study in Sweden to try to figure out why the reason for anemia. And of course, that is multifactorial. But one very strong risk factor for anemia is the iatrogenic phlebotomy that is ongoing in the neonatal wards. And in fact, we were quite surprised when we found out that during the first 2 weeks at 2 university hospitals in Sweden, approximately 57% of the blood volume was lost because of iatrogenic phlebotomy. That would be corresponding to if any one of us would end up in the intensive care unit and we would lose over 3 liters of blood. So it's a substantial blood volume that is lost. And one thing that is lost when taking early blood samples in these babies is of course, the fetal blood components. And we were interested in looking at fetal hemoglobin, as that is for sure associated with oxygenation in these babies. And we found that the faster the baby drops in fetal hemoglobin, which is seen on the figure to your left, are the babies with any ROP, the higher, the faster that the babies drop in fetal hemoglobin, the higher the risk for any ROP. And here is the fetal hemoglobin week 1, the mean values week 1, and you can see that there is a drastic change in the risk for ROP depending how much fetal hemoglobin you have. In a term baby, it takes approximately 2 to 3 months to go from around 70% of fetal hemoglobin down to around 20%. But here you can see that this was really speeded on, and only after 1 week, the levels had decreased to approximately 50% in the babies with any ROP. And of course, this has an impact on the oxygenation. And of course, the more blood we take from the baby, the more transfusions are given. When it comes to, this was when we looked at erythrocyte transfusions. And one could only speculate in what other factors the babies do have a change in when we exchange the fetal blood with adult blood. For instance, all the plasma that is given to neonates is from male donors, as there is a too high of a risk to give plasma from female donors because of the immunological reaction that might take place. And we know from studies that, for instance, sex steroids are tremendously different in the plasma that is given to these babies when compared with the female babies especially. So I was quite interesting to see this publication from September this year that actually had looked at the sex of the donator when it came to red blood cells. And in fact, most neonatal morbidities, except from ROP, had a reduced frequency when the donation was from female red blood cell donors. So it seems as it has an impact from where the in this case red blood cells are coming, but probably also the composition of the plasma of the babies that when they are being transfused. So this led us to starting to speculate whether we actually could transfuse rather erythrocytes from cord blood rather than from adults. So we have a project named NeoRed where we now have produced a component of cord blood erythrocytes that we know contain approximately 77% of fetal hemoglobin compared to in adult blood where it is actually less than 1%. And we will now start a phase 1 study to look at safety when delivering fetal erythrocytes to preterm babies. There are actually a couple of studies that has performed this without any safety concerns. So this might be one way to maintain at least fetal hemoglobin in these neonates. We have also shown that the levels of fetal hemoglobin is strongly associated not only with ROP but also with BPD. And looking at the proteome of extremely preterm babies, we did a pilot in 14 babies. We have now looked at 220 babies, and we have exactly the same findings, namely that most of the proteins associated with ROP belongs to the group of hematopoiesis, which again points at the importance of blood components when it comes to neurovascular growth in these babies, and of course also proteins associated with angiogenesis and neurogenesis, as well as immune function. So as we heard, we have also put a lot of energy into predicting which babies are at most risk, as we know that 70% of the babies we screen will never develop any ROP, so we are exposing these babies for stressful examinations, and lots of resources are going to this screening. So by focusing on the right patient at the right time, we could be more specific and then use the resources in an optimal way. And so far, most prediction models that are out there are using postnatal weight gain to predict severe ROP. We have now, thanks to a very, very good statistician working in the group, Aldina Pivodic. She has used data from the Swedish patient registry in ROP, the SWEDROP, and together with the SWEDROP group, we have gathered information on almost 10,000 babies and developed an algorithm that actually predicts if the baby needs to be screened at all or if it can be released from screening, depending on the outcome from the Sweden patient registry. And it is available. I'm so happy because they made it available to before this talk. So you can actually go to this homepage, and it's free of use. And all you have to do is you put in the baby's gestational age in weeks and days, the weight of the baby, the gender of the baby, and then you push calculate. And by doing that, you will compared to the Swedish babies, this model has been validated in an American cohort, in a German cohort, and in a modern Swedish cohort, which was not used to produce this algorithm. And it has a very high sensitivity, almost 100%, and a 55% specificity. So I would suggest you to start to use it and validate it in your own settings before using it in the clinic. But for us, it is extremely valuable. In this case, this baby is suggested to screen normally, because as you can see, this is the baby's confidence interval, and the red dot here represent babies in the SWEDROP registry that has been treated. The blue area is babies that has not been treated, and this baby has a 5.39 individual risk of needing treatment for ROP. This is compared to this baby born in week 27, weighing 1,100 grams. And this baby is outside the risk of being treated. So according to this algorithm in Sweden, we can safely release this baby from screening. So by putting in only birth characteristics, we could actually release 50% of the babies that we screen today from screening examinations. We are now validating this algorithm and implementing it in the clinic. We have taken this one step further, or our statistician Aldina has taken this one step further, and also entered screening data at when we see the first sign of ROP and the age of the baby. And by using machine learning, we can reduce another 25% of the babies from screening. So by using this, and this will also come on the page that is in the headings here, but not until after Christmas we will enter the screening information. But for now, you can absolutely use it for birth characteristics, which might be interesting for you as a neonatologist to know if your baby, how high risk it really has to develop ROP. We were interested in looking at the babies that became blind in Sweden to really try to understand what was the reason for this. And doing that, we found that in approximately 2/3 of the babies, it was most likely due to that the guidelines had not been followed. For instance, the baby was not screened at the time it could have been too sick, or misunderstanding of the information in the patient record, or it was not treated timely when it had signs of being treated, or it was not correctly interpreted the findings of the ophthalmologists. So this has also been observed in other settings. For instance, in the Canadian network, they proposed that a standardized measurement has to be present in order to avoid unnecessary blindness in these babies. Therefore, we have constructed now a digital decision support screening tool where every entity has to be entered into this digital record in the right eye and the left eye. And by doing that, the ophthalmologist get a suggestion when to screen again, or if the baby needs to be treated. It is also possible from this digital record to enter the data directly into the Swedish patient registry, which is a fantastic improvement in handling the clinical data. So as you also heard, we have become very interested in nutrition, and looking at nutrition, I wouldn't hesitate to say that the most important nutritional component is mother's own breast milk. And of course, the mother's own breast milk is, the quality of that is totally dependent on what the mother eats. And as we have seen that the components of the milk is really reflected in the intake of the mother's nutritional. And we have just finalized a study where we have looked at the brains in mice with different nutrition, and the offspring's brains when the mothers were given different nutrition, and especially different fatty acids, and the composition of the brain is very much reflected by the nutrition of the mother. So this is not a surprise, but it has to be talked about so we can give the mothers the best prerequisites for the if they deliver a baby preterm. And it is not about the full amount, but it is actually that any maternal breast milk is good. A component of maternal breast milk is, of course, fatty acids. And as seen in this slide, during fetal life, the mother is actively transporting arachidonic acid to the fetus all over the gestation. And this is especially during the 3rd trimester. And you can see the mother's levels here and the fetus levels here. And this is, of course, the molar percent, but it is higher arachidonic acid in the fetus. And when it comes to DHA, omega-3, this is omega-6. Omega-3 is especially increasing in the fetus and reduced in the mothers during the end of the 3rd trimester. And we know in the preterm babies that there is a drastic drop in these fatty acids after birth. Already after 1 week, the levels are much lower than during fetal life. And we also know that these factors are important factors for building tissues. They are responsible for about 60% of the retinal composition and the brain composition, and arachidonic acid is extremely important for most membrane structures. So we did first a trial looking at different parenteral nutrition, and try to give a compound with fish oil to see whether that would decrease ROP. We did not see any impact on ROP, but looking at the levels of fatty acids, we did see that in the babies with severe or any ROP, as in this case, that they had lower arachidonic acid levels. So it seemed from that trial that arachidonic acid was also important for ROP development and not only DHA. And in looking in the literature, there are quite conflicting results. Sometimes it has been shown that omega-3s are beneficial, and in some studies that outcome has not been shown. So we performed a multi-center trial in Sweden giving an enteral composition of both arachidonic acid and DHA. Today, there is no parenteral nutrition that contains arachidonic acid and DHA in this composition 2:1. This is approximately the composition that we have during fetal life. And we did this trial in 206 babies, and ROP was the main outcome. And we did it in approximately It took approximately 2 years, and we finalized the study in end of 2019. And we published our results in February this year. And we did see increased levels of DHA in the group that had this parenteral supplementation, actually from birth all the way to 40 weeks. And we started with 0.1 ml enterally, and it increased slowly to 1 milliliter in the end when they reached approximately 40 weeks. So we did see significantly higher DHA levels, especially in the end of the intervention. And we also did see increased arachidonic acid levels. And we were quite surprised by the finding. Of course, we had hoped for positive effects on ROP, but we did see that we could reduce severe ROP, which was the outcome, and that is ROP stage 3, or if the baby needed treatment. And the number of infants with severe ROP in the interventional group was reduced by 50%. And this was quite an impact on this treatment. We are at the moment now looking at the MRIs of these babies, and hopefully we will have the outcome of that examination in the beginning of next year. So then trying to try to understand the relationship between arachidonic acid and DHA on ROP outcome, we did a secondary analysis that was just published. And we did see actually that the babies with severe ROP had significantly lower arachidonic acid levels. This is during the first 12 days, and this is during the first 8 days. And this is DHA. They also had lower levels. But what was very interesting, and I think this probably explains why we have so different outcomes in different trials, is that it seemed as the impact of DHA was more present if we had a certain level of arachidonic acid. So if the arachidonic acid levels were below in our trial, in our setting, it was below approximately 7.7, then we could not see a positive impact of increased DHA. But if we had sufficient arachidonic acid levels, then we could see decreased odds for ROP severity. So it seems as a combination is necessary, and as said, a certain level of arachidonic acid is present for DHA to have its full action. So what about treatment? Well, as most of you probably know, laser has been the golden standard, but it is now approach by anti-VEGF. And when it comes to laser, we know for sure that the babies will have a reduced visual field sensitivity. We know that they have an increased risk of myopia. We know that most babies have to be put under general anesthesia. We also know that if it is correctly performed, there is a very low risk of recurrence. And we have control of long-term outcome. This is a trial, or it's not a trial, but it is a study that we just performed in Sweden. We looked at all the babies born below 24 weeks, as Sweden is unique in saving these babies. And we looked at it from 2007 to 2018, and 399 babies survived till 40 weeks that were, ridiculously low birth weight, as we heard before. And we looked at a number of infants that needed a second treatment after laser. And these are the 7 university hospitals in Sweden. And as you can see, the dark bar is it's a large variation of the dark bar, and that is number of babies that needed retreatment. So it seems as recurrence is dependent on how the babies are treated with laser. And then we did another investigation to look what was the reason for this. And I believe it is what you see here. It is if the babies is treating with laser and you have skip lesions. And we now know that in order to do a good laser treatment, you have to do RETCAM in association with the laser treatment. And that is now being done in most centers in Sweden in order to identify skip lesions during the laser session and then put laser spots so we do not have any skip lesions. And by doing that, I'm pretty sure that everyone can reduce the recurrence rate when doing laser. When it comes to anti-VEGF, and I've listed the different anti-VEGF drugs here, we know that the babies have less myopia. There are still not good trials to show how the visual field sensitivity is. I would like to stress that anti-VEGF does not act only on the vascular tissue, but also neural tissue is dependent on VEGF in order to develop. It doesn't have to be given under general anesthesia in all settings. We do it in Sweden, but I know there are many countries that don't do it under general anesthesia. And we do know that the babies that do get anti-VEGF, that they have a high recurrence rate. Approximately 1/3 of the patients will have recurrence. And we don't know really when it happens. And we do not really know, not have very much control of long-term outcomes. The first publication came now 10 years ago, and it was then said that this drug would not escape the eye and turn up in the circulation. Now we know better. We know that it does, and especially that compound that was used by this time has an active transport part of its anti-VEGF to the bloodstream. So there have been several publications regarding outcome and anti-VEGF, comparing it with laser. However, most of them have used historical controls, and there, I would say, is not a good study looking at long-term outcome from a randomized trial. As we will hear, there are some coming up, but today we do not have, regarding neurocognitive outcome, any good randomized prospective trials. In this publication from 2019, it showed higher mortality and poorer cognitive composite scores in the bevacizumab group. However, I would be careful looking at retrospective studies and the outcome of that. There was a couple of years ago a publication when a baby was giving anti-VEGF, and later the baby had a neck session, and this is the levels of VEGF in serum measured after bevacizumab was given. And this is 6 hours post-treatment, where you can see that the levels of VEGF drop dramatically. And it was suspected that this baby actually had neck because of the injection. But of course, that cannot be said for sure, but timely, it fitted very well. So there has been one large study, the Rainbow study, looking at, which is a prospective study. It was comparing 2 doses of Lucentis, which is the smaller molecule, which we know have a shorter half-life. And it was compared with laser. And the aim of this study was to have the drug approved for this indication. And this study was performed in 2000, and it was presented in 2019. So the drug had been used for many, many years off label. Looking at the outcome of this trial, the Rainbow study, there was a non-significant result on the primary outcome. It was shown, it was said that Lucentis was efficient and tolerable, but there was one death in the Lucentis group and one case of endophthalmitis. And when you have endophthalmitis in a preterm baby, the eye is lost. There is nothing you can do, and I would say for sure the baby becomes blind in that eye if you have an endophthalmitis. They also stated in this publication that VEGF levels in plasma was not affected, and I guess this is true. And for that, the EMA approved ROP for this indication in October 19. I would like to spend just some words regarding measuring VEGF levels in relation to ROP in preterm babies. And it has been discussed quite a lot what media to use when you should measure VEGF when it comes to cancer studies and tumors, whether it should be measured in serum or plasma. And I would say it's totally dependent on the physiology you are interested in. And looking at that, I would like to stress there was a publication from India from Professor Anand Binekar, who did show that there was a case with aggressive ROP that had a thrombocyte transfusion, and then the aggressive ROP completely settled down and the baby did not need any treatment. And that actually made us very interested in looking at platelet levels and in relation to any ROP. And we did find that the babies that had needed ROP treatment, not only aggressive ROP, but any ROP treatment, that they had lower levels of platelets, especially during the second phase of ROP. So that would be from week 30 and onwards. Together with Professor Louis Smith, we performed an experimental part of the study where we actually gave mice platelets after they had been exposed to oxygen. And by doing that, we could see that the area of neovascularization was significantly reduced. And we could see that one factor that contributed to that was that mRNA for VEGF in the retina was actually the expression of mRNA for VEGF was significantly less pronounced. So it seems that platelets are important for this disease, and we have shown that there is a correlation between platelet level and VEGFs. So we believe today that platelets are important for vascularization, neovascularization, and that they contain microvesicles with VEGF. So looking at VEGF in these babies, we should absolutely measure the levels in serum and take the levels from the platelets into account. So by looking at different studies, the results, whether we have an impact on VEGF, circulating VEGF in the blood or not, is quite dependent on in what system we measure it. So I think that is the reason for the study, the Rainbow study, not to show any effect, any of plasma levels. But maybe we would have a different result if we looked at the levels in serum. Most likely, I would say. So this is the third question. So now after 10 years of use, are there any pharmacokinetic studies available on anti-VEGF in preterm infants? Yes or no? So 50-50. Well, I would say that today we still don't have any good pharmacokinetic study. We still do not know the lowest dose that will give us efficacy. And I think, I'll see if I can, no, I have to do this again.
Sorry for that, Professor.
No, it's okay. If you can stand it, I can do it. Okay, so there was a Cochrane review 2018 which stated that there are insufficient pharmacokinetic studies. We have no prospective long-term follow-up studies, and we do not know the systemic effects on different organ systems. So further studies are needed to assess this outcome. And I think this study led by David Wallace in the United States really reflects this whole problem. They are now performing an NIH-funded study where they are down to 0.6% of the dose that was used in the first study produced or published in 2011. And that study it has been shown that this dose is as efficient. So I think this really reflects the problem when you introduce a new drug in neonatology without doing proper pharmacokinetics to try to titrate out the lowest possible efficient dose. Since this is a systemic exposure to these babies. I am very, very happy that the regulatory bodies now ask for long-term follow-up of the studies performed. And that is the Rainbow study. It is also the study from Bayer, the Firefly study, where Eylea has been tested for this indication. And it is the low-dose Avastin study that I just mentioned. And actually the first publication from the Rainbow extension study was published in August this year. And it demonstrated that the highest dose of Lucentis, that the babies that received that they had less myopia than after laser, 5% versus 20% after laser. And they also looked at growth outcomes and respiratory outcomes, and they could not see any significant difference regarding these outcomes. So I think this is reassuring. We are still awaiting the neurocognitive outcomes. And I'm very, very glad that, as I said, the regulatory bodies now ask for long-term systemic follow-up of these babies. So by saying that, what could be done today to prevent ROP? Well, of course, to sponsor the mothers to breastfeed their children. And of course, nutrition of the mommy is important. It is also important to try not to have too much of a variability when delivering oxygen to the babies. And think twice before you take a blood sample, or if possible, use micromethods. And naturally, infections lowering the platelets are not warranted, but that you know better than me. And of course, optimized nutrition for the babies. I still believe we do not know the optimal way to nutrient a preterm baby. We are starting on the tip of the iceberg to identify certain macronutrients that are important. However, the balance between these, I do not think that we are there to have the optimal composition yet, but it is a work that needs to be looked into more, because yes, there are for instance, the fatty acids are important for neurovascular development. That I think we have shown. So by saying this, I would like to thank you very much for listening. And I would like to thank all my collaborators over the world and in Sweden. Thank you.
Wow, that was an amazing lecture, Professor Anne. It was, this was really one of the best lectures we have had so far in the series.
Thank you so much.
Shall we stop sharing and go on to the discussion part, if it's okay with you?
That is perfectly fine.
So, we will have a 2-minute break of a video clip. After that, we will go on to the panel discussion. Thank you. Friends, now we have a much awaited discussion coming up. To moderate today's discussion, we have two leading neonatologists of India, Air Commodore Shamsher Singh Dalal, Professor AFMC Pune, and Professor L.S. Deshmukh, Government Medical College, Aurangabad, India. So, hearty welcome to you both for to this session, and thank you so much for agreeing to moderate this session. Over to you for the next 20 to 30 minutes, depending on the Professor Anne's timings. I hope it's okay, ma'am. 30 minutes, 20, 30 minutes is okay? Yeah.
It's perfectly all right.
Okay. So, over to you, moderators. Kindly take over. Thank you.
Thank you, Dr. Manas. At the outset, I'd like to compliment and thank you, Professor Anne, for an excellent presentation, very informative, very enlightening. Thank you so much. Also, I'd like to thank the organizers for selecting a topic which is very, very relevant to especially the pediatrician and neonatologists from India, where the largest number of premature babies are born. and the facilities for neonatal screening for ROP as well as treatments are not so widely spread and not so easily available. And secondly, to inviting Professor N for giving this talk on this topic, the true legend in the field of ROP. Thank you. Now we'll, as Professor N has said, and we all agree that we cannot 100% prevent ROP, but we can decrease the incidence to a great extent. And many of the strategies which Professor N has highlighted can be implemented in most of the NICUs by just improving the quality of care, reducing the iatrogenic blood loss, decreasing the variability in the SpO2 fluctuations, and early breastfeeding, nutrition, improving the nutrition of the mother are really implementable, easily implementable, but require lots of effort from the people working with the newborns. With this, I will just the few questions which I got from the participants. The first question is from Dr. Hamid. This question is, some literature claim that there is an association between iron overload due to multiple RBC transfusion and ROP. What's your take on this, Professor?
I'm sorry, I did not capture the question.
Yeah,
What?
his question is that there an association between iron overload due to multiple RBC transfusion and ROP? That means the effect of ROP of RBC transfusion on ROP, is it because of the iron overload or it's just because of the presence of the adult hemoglobin which is causing more oxygen delivery?
I think I really believe that it is the anemia that is causing the risk for ROP and not the transfusions in itself. That is my my absolute conviction. But of course, there is where we have looked a lot at what happens when you transfuse the babies, and it really seems that the anemia pre-transfusion is the main risk factor.
Okay, thank you, Professor Ann. The next question is, did you find any association between oral arachidonic and DHA supplementation and NEC, increased risk of NEC, your study?
Increased what?
NEC, necrotizing enterocolitis.
No. In fact, we saw a little less NEC in the study, but it was not significant. But it seemed as these babies have a little less of inflammation all over, and that is sometimes goes with the neck. But we had a little less neck in the invention group.
Okay, another question from Dr. Bharat. He says that occasionally we encounter babies with thrombocytosis in NICU. Did you look at the thrombocytosis, whether these babies had lower incidence of ROP?
With what? Lower incidence of ROP when?
Increased platelet counts we encounter in babies. So did you find any association between increased platelet count with thrombocytosis and decreased risk of ROP in your study?
No, we have not seen that.
Okay, so low platelet count has an association, but increased, if I correctly, there's no association.
No, that is correct. But we are now starting to think that, and we have looked at that giving platelets from adults, that the adult platelets might not be the same as the fetal platelets. They might have completely different missions in the human. So it seems as the fetal platelets are more into maintaining vascularization and neural development, and not as much in clotting as the adult platelets.
Dr. One question from my side on this of it. As you said, some evidence is there that even if we give transfusion, female transfusion donor, transfusion from female donor is found to be better. Do you recommend that mother's blood better than the other donors if the blood groups are matching?
If I had a preterm baby, I would give them my blood. But I would also save cord blood to give to them the full blood. But that is only, I must say, this is more of a feeling thing than I can say that it is. I don't have scientific evidence other than that publication I showed you that it seems as other morbidities benefit from female cord erythrocytes. But I think it is interesting, and of course we understand that we have looked at different growth factors in plasma given, and it is a huge variability depending on who has given the plasma. And of course we know that, but I think we will be more and more aware of those things later on.
Yeah, I just thought maybe mother blood will have more growth factors, maybe
Exactly.
transmitted across the placenta from the baby side or mother to baby side.
Yeah. We had a very prestigious professor in neonatology 30 years ago who always gave the babies full blood from the cord during the first week, 1 ml, I think, and that was his belief, and they did quite well.
Maybe the delayed cord clamping will help in reducing the delayed and reducing the transfusions requirement.
Yeah.
For further questions, I'll hand over to Professor Deshmukh.
Yeah, thank you, Dr. Dalal. Good evening, everyone. Hi, and thank you, Professor Ann, for this great presentation. It was very insightful, and you could compress so much of information in a span of 45-50 minutes. And it was very aptly organized by the organizers for the pediatricians and neonatologists. You might be interacting with other ophthalmologists, but for pediatricians and neonatologists, it was very enlightening for all of us to refocus on the ROP. Because what we have found recently of late, in last 5-10 years in India, as the expansion of neonatal care to the peripheries at the district places is happening, through the government programs as well as through the private hospitals, more and more babies are surviving. And we are facing this extra burden of ROP, which is unrecognized. And now in India, at district level, there are almost more than 700 SNCUs, which are called as sick newborn care units, which provide level 2 care, where they manage babies with oxygen and maybe CPAP, not ventilating. Those units are not ventilating. But the biggest issue and biggest challenge for us all is screening the babies and not missing the babies, which is not happening at present. It is happening in bigger hospitals, in public hospitals. I am speaking in some of the private hospitals, but it is not happening regularly. And as you know, India and China, they have largest number of births per annum. And we have very high burden of premature births and very high need of babies needing this ROP screening and treatment. But on the top of that, ROP is such an area where very few ophthalmologists, forget about pediatric ophthalmologists, very few ophthalmologists are interested to become a ROP specialist. And by some recent literature and recent data, there are just around 200 retinas or ROP specialists across India. With such a huge burden, there is a dearth of ROP specialists, but there are few initiatives which have happened over last 5-10 years with the use of telemedicine or tele-ROP by the use of RateCam, and some pilot projects were done, and subsequently some of the centers have adopted that model. So some screening is happening and some specialist opinion is reaching to the peripheries. But it needs a lot of improvement, but your talk was focused more on prevention, so that I appreciate very much. Second thing I appreciate is you focused more on anti-veg therapy, VEGF therapy, which is also well appreciated. And so wonderful lecture once again. Thank you, ma'am. I take up next question. We all know that the sepsis is an important risk factor for ROP. So prevention of infection is key for prevention of ROP. But is there any difference vis-a-vis bacterial versus fungal sepsis in terms of risk of ROP or risk of severe ROP?
It actually seems as fungal is worse when it comes to the risk for ROP. And we do not know why, but there are several publications, and also we have data from our group that shows that fungal ROP, fungal sepsis seem to affect biomarkers associated with severe ROP more severely. So I don't know what it is, but yes, fungal is worse.
Okay, so we do face a lot of fungal sepsis, and maybe we have to be very extra careful in those babies to screen and follow up them for a longer period of time. Another question from Shamnad is, are there any group of neonates in which you recommend anti-VEGF therapy upfront, like zone 1 APROP?
Yeah, absolutely. You're fully correct. And I missed to stress that in my talk, but there is definitely, it has been shown, and I believe that if you have severe zone 1 disease, anti-VEGF is needed. It is for some reasons, and one reason is that it seems that it is a higher chance of not having retinal detachment if you give anti-VEGF than if you give laser. And I think that is that if you give a low dose of anti-VEGF, you don't get a high rebound effect. If you give laser, you do get quite a severe inflammation, and that might give a second rebound. Another positive thing with giving anti-VEGF in very posterior disease is that we know that it usually takes at least a month to have a recurrence. And during that time, the vessels may grow a little bit further out in the periphery. So if you need to treat with laser, you will not destroy as large area of the retina. So for sure in Sweden, if we have severe zone 1 disease, we always treat with anti-VEGF first, as low dose as possible. And Lucentis for sure is preferred. And then we usually wait, but we do a second laser treatment when we see that the vessels start to develop abnormally again. Because if we wait too long, we do it between a month, 4 to 8 weeks after the first anti-VEGF treatment. Because to be sure that we won't have a recurrence that we don't have control of. And we want to finalize the screening so the babies can go home and not to need to be screened every once or twice a week for months and months. That is not doable.
Okay, yeah. And related question I just want to ask is, in Sweden or across Europe, is Lucentis preferred over the Aventis? Or is there any head-to-head comparison? Bevacizumab versus ranibizumab?
Bevacizumab is not accepted for ROP, so there is no indication for Avastin. Therefore, bevacizumab is the anti-VEGF drug given these days in Europe mostly.
Is it always an unlicensed? Is it still unlicensed and off-label?
Avastin is, yes, but not Lucentis 0.2 milligrams. That is approved by EMA for the indication of ROP.
But are there any concerns with Lucentis about crossing the blood-retina barrier and causing some more problem with the neural development or cognitive development?
Yeah, those discussions have not ended. It's still ongoing, and there are several studies now coming up regarding the Rainbow study, cognitive development. Everyone is awaiting that study to see if they could see any trend in outcome. We have looked a little bit at in our patient registry, and this is very preliminary data, and I would not, be very sure about it. But it seems that we do get a little bit of different outcome when we use laser and anti-VEGF. And it might be that one causes more inflammation, the laser, and that might be more related to neuropsychiatric outcome. And maybe the anti-VEGF is more related to neurocognitive outcome. But that is only a theory and hypothesis. But we have to remember that they have different actions, and different actions affect the brains in different manners. And I
Yes,
think we in the end, we will see this, that it is not as easy as we would like it to be, but
Yeah.
it might be that we get different outcomes.
Right. Yeah. So thank you for that. Dr. Dalal, can you take over? You are muted. Please unmute yourself.
Yeah, Professor N. The next question is from Dr. Akash. What is the role of beta blockers in prevention of ROP? There are few studies which have shown that use of beta blocker has decreased the progression of ROP. Is there any role in prevention?
Yeah, this is a very nice, good question, and we don't have the answer on it, but there are some experimental studies that has shown that it theoretically could have effects. We did an experimental study that did not show that. And now there is a trial ongoing with propranolol. But it is given already in stage 2, and as I showed on my natural history, a lot of those babies will never develop severe disease, and still these babies are given quite high doses of propranolol that we know affect the babies, and we know it may affect the brain development. So today, I cannot say that it has effects. We know that propranolol has anti-angiogenic effects. We use it in ophthalmology when we treat hemangiomas. But giving a developmenting baby this drug, I think we do not have the answer. And the way the trial is conducted, I think it is given now too early. If it will have effect, probably it should be given when we see more severe disease, so that we won't expose as many babies to this drug. But I don't know. I might be wrong, and for sure we know that the drug has anti-angiogenic effects. The question is how systematic effects do we see, and how good is it to prevent treatment.
So do you use in your practice or no?
No.
Okay.
Nope.
The next question is that we know that the intermittent hypoxia has been associated with increased risk of ROP, intermittent hypoxemia episodes.
Yeah.
And so which is more dangerous? Is the depth of the hypoxemia the degree to which the saturation falls, or is the duration? Out of these two, is the duration of the hypoxemic episode is important, or is the decrease in the saturation which is important? In
our study, we could see that it was not the duration of hypoxia, but rather the times that the baby had the saturations, that was more important. I think every time you switch a tissue on and off, that is a risk. We know that harmony in the body is the perfect state. And we could not see that the time of hypoxia was the strongest factor. It was times of variability. That was the strongest risk factor.
So do you think
But that could it could be different in different postmenstrual ages. That we have not looked at.
Okay, just a continuation of that. Now, some data is coming very retrospective that if you use lower saturation during initial few weeks of life, followed by the higher saturation,
yeah,
they are found to be better. So do you recommend that we should start practicing like in Sweden? You saw when we started using the saturation of 91 to 95, you had an increased incidence of ROP in your country.
Well, if I had heap of resources, research money and research personnel, I would absolutely conduct such a randomized trial to give the most immature babies lower targets, and then when they come up to the second phase of ROP or when they are a bit about 32 weeks, I would increase. I would not be afraid to increase the saturation. Unfortunately, those trials are not haven't been done. There are some trials that have one trial, the stop rope trial, that actually increased the oxygen levels when you started to see neovascularizations, and that did demonstrate less severe ROP. So if I have a baby that I'm treating, I tell the parents and the NICU personnel that don't be so afraid now to keep the babies a little bit higher. But this is my clinical experience for many years, but I'm still awaiting the trial that actually can demonstrate this. But yes, I believe you are on the right track.
Thank you. Now, the next question is, what is the maximum number of anti-VEGF doses we can use?
In one patient?
How many times we can repeat the anti-VEGF doses in case we are not seeing an adequate response? Or do you recommend that we go for laser after first dose?
If we have a very severe case in Sweden, we always start with anti-VEGF, I would say, if it is a very central disease. I think now, well, there are, of course, I also believe that the different compounds have different, as they have different half-lives, they might be different efficient. I don't think we can say any number that is a maximum number. In my setting, we have never given more than 2 doses, but I cannot say that that is the maximum. I think that has to be judged by the treating ophthalmologist together with the neonatologist. But I would always I would like to be a bit reluctant, because we know that it is in the circulation. If you give ranibizumab, it's probably in the circulation for a month, and regarding bevacizumab, it is for a longer time. So I would be careful, and if it doesn't have effect, the first dose doesn't have effect, and not the second either, then I would of course go for laser, because then I don't believe the third dose would have effect either.
Another question is, like in India, we have seen that ROP in the babies over higher gestational age and birth weight. And because of that, our NNF, National Neonatology Forum, is recommending screening baby up to 34 weeks and birth weight of 2,000 grams. So what do you think is the reason that these larger babies or more gestational age and the more birth weights are developing ROP in India?
Well, if I just guess it, I guess it is the oxygen is to be blamed, because that is what we see from other settings. I have a difficulty in understanding that it would be nutrition or inflammation. Of course, some mothers of India might also not be so well nutrited, so that makes these babies a little bit more prone to have less vascularization later in gestation. That could be one reason, but if I was to pick one factor, I would say that you should look into oxygen delivery in these babies.
And a larger proportion of our babies are IUGR.
Yeah,
Intrauterine
exactly.
growth retarded babies. So
Yeah.
that may also be contributing.
Yeah, that is what I think, that we have seen that if the biomarkers that we know are associated with ROP, if they are really low at birth, then these babies have a hard time to catch up. So it's really a lot is decided already at birth, and that is why I think this algorithm I showed you works so well, because already at birth we know what babies are at highest risk. And I think we have to focus on those ones for the brain and the vascular development.
Yeah, few more questions. Is it okay? We continue. Yeah, Professor Desmond.
Thank you, Dalal. So, continuing with our questions, is there any role of erythropoietin or iron in the development of ROP? If we give
I think
erythropoietin or maybe iron supplements, does it increase?
I think with the erythropoietin, it's dependent a little bit where in the phase of ROP it evolves. So I think it is again the reason for why we see increased levels of erythropoietin in some babies with ROP. It's because of the anemia that probably drives the increase of erythropoietin. So far, it has not been shown that by giving erythropoietin you could decrease the risk of ROP. In fact, in some studies, it has increased ROP. And I think if you give erythropoietin later, at higher postmenstrual ages, I think definitely there is a risk for increasing ROP.
Yeah, right. Just another question related to oxygen targeting in your unit. In cases where there have established ROP, what are the oxygen targets?
We don't change the targets. They are the same for every baby, independent of ROP stage or gestational age and postmenstrual age. So they are now between 91 and 95, I think. They are following the boost criteria.
Yeah, 91 to 95. Yes, 90 to 95.
Yeah.
Right.
90.
Yeah. So it is same irrespective of the ROP status.
Mm.
Yeah,
It's
thank you,
just
ma'am.
that it's just that I recommend the parents not to be so careful, because most of the in most hospitals now the parents take care of the babies when they become a little bit older. So I just advise them not to be so careful to put down the oxygen delivery to the babies, rather to keep it a little bit higher if I see that ROP starts to develop.
Yeah.
Even after treatment, laser or anti-VEGF treatment, you maintain the same saturations or you alter?
When we give anti-VEGF treatment?
Yeah, anti-VEGF or after the laser therapy, do you continue the same saturations or different targets?
No, the same saturations.
Okay. So one more question. It's related to, I guess he is asking about hypoglycemia. If it is treated in extremely preterm babies, does it increase the risk of severe ROP? Because hyperglycemia and hyperinsulinemia is one of the risk factors.
Absolutely, that is very much true. We have seen that hyperglycemia is associated with ROP, and also we know that in babies with hyperglycemia they have lower IGF-1 levels, and they are mostly more IUGR babies. And it is the question is what is what, and we know that some of the fatty acids are associated with the metabolism, the glucose metabolism, and I don't think we really know what is what, but definitely we know that early hyperglycemia is associated with an increased risk of ROP.
Yeah, right. So one last question. What is your experience regarding neonatologist or pediatrician instead of ophthalmologist doing the screening with red cap?
In Sweden, it's mostly the ophthalmologists that do the screening, but we do have in some settings neonatal nurses that do take the images, and the ophthalmologists look at the images. So I think this could be a good person that take good images, could have any background actually. It's all about technique, and I think the important thing is that the images are interpreted by a knowledgeable person, but that can be done from distance. A lot of this can be done from distance. So I think it's important to educate someone who has an interest in this, and then anyone could actually do it with a good interest.
In India, in many centers, optometrists are doing the screening. The images are shared with the live or maybe shared subsequently, and they are interpreted by specialists. Started with the pilot project of KidROP, and subsequently other ophthalmologists adopted that model. And it is working very well. So it needs little bit of training, and a trained optometrist or technician can do that.
Yeah.
But some of the
And what
nurses
is
are doing that.
I think that's very, very good. And we have to remember that the indication for treatment is really the central view, if the baby has plus disease or not. And that then it's not so difficult to take the images to get a good central image. Of course, we would like to see the ridge, but I think this is a very, very good way to have good screening to take retinal images.
Yeah, thank you. One last question before we finish, ma'am. Yeah, there is something called as hybrid ROP. Any comment on that? That terminology is recently being used. Hybrid ROP.
That is actually the first time I hear this word.
Yeah, that is what our ophthalmologists are telling, that they are using this terminology in India because they are seeing cases where there is a plus features of plus disease plus fibrovascular bundle or scar somewhere. Simultaneously, plus disease plus fibrovascular ridge or proliferation.
Okay. I must say that I feel a bit knowledge here, because this is not something that I've come across, the hybrid ROP. What is it, a central disease with plus disease with fibrovascularization, you said?
Not necessarily central disease, but plus disease with an fibrovascular ridge or proliferation. And that has been recently, that terminology has been used in operational guidelines also, National Operational Guidelines of India, which were published in 2018-19.
So it's not stage 3, it's more fibrovascular changes.
Yeah, right.
So would it be that the disease has gone a little bit long when you actually find it? That it could have been there for...
Yeah, that might not have been picked up earlier.
Yeah. Sounds, because on the description, I would, if I saw such a patient, I would say that this has been, it's been too long standing. You should have treated this patient prior to this morphology. But I cannot say because I haven't seen it.
Yeah, that is not surprising, but because the follow-up is very erratic in many of the centers.
But we do see a change, in the ROP development. We see that we have to follow the babies longer, for more than 40 weeks. We see that in some babies, the vascularization actually does not reach the periphery. In the most immature babies, we definitely see a changing picture of ROP as you get better and you save more babies. So
yeah, thank you, madam. Thank you.
Thank you, Professor Ann.
Thank you, Professor, and thank you, Dr. Manoj. Over to you for the next part.
as we keep on saying in most of our sessions, all sweet things need to come to an end. And then I would really apologize to Professor Anne for keeping longer than what we promised. Before we close this, we have the Secretary of IAP Neonatology chapter, Dr. Rajesh Kumar, with us. Dr. Rajesh, are you there for a few words? Then we'll wind up the session.
Okay. Thanks, ma'am. Thanks, Professor Anne, for nice lecture. And still, we don't have answers about whether they use Avastin or Lucent in India. And our National Neonatology Forum, that is a body of neonatologists in India, it recommends Avastin over Lucentin. And still, we don't know what dose we should use. And still, it is a developing field. I think the lower dose will be a better option. And in the future of the few studies, will be clear about the dose, what dose you should use. And thanks again, ma'am, for the nice lecture. Thank you.
Thank you.
Thank you so much. Now we will close this session. I have great pleasure in expressing our gratitude once again to Professor Anne Hellström, one of the legends in pediatric ophthalmology as well as now in neonatology. We are all admirers of you. Thanks to the work you have done in the last 20 years, and it's a huge honor for us to have you in our forum, ma'am. I also would like to extend our sincere and hearty invitation to you to join us for the grand finale of this series IAP Neocon scheduled from 10th to 13th. I'll be contacting you personally for this, man. Thank you so much, Professor.
Thank you.
Thank you. I would
Bye-bye.
also like to thank both the moderators, Air Commodore Shamsher Singh Dalal, Professor FMC, and Professor LS Deshmukh from Aurangabad for moderating this session so wonderfully. So nice of you to keep the session so live even after exceeding half an hour. So thank you so much, both of you.
Thank you.
Thank you.
Bye-bye.
Bye.
Good night.
And at the end, let me thank all of you from all over the globe who has joined us and will be watching this presentation in the next 24 hours. We have almost 7,000 plus registrations, and we are really truly honored to have you with us in this series. Now, this is the 43rd session. We hope to have the golden jubilee in the 50th session along with our grand finale that is in March. So I would invite all of you for that as well. On that note, I would just wind up with the invitation to join our next webinar. That is on 23rd December. That is the Christmas Eve. Thursday again, the same time. The topic is something we had discussed and left off in between because we are discussing preterm babies all these last 2 months, and this is probably the one of the last topics in preterm care, neuroprotection. Not the least important, but one of the topics that we have left out so far, neuroprotection preterm infants. And to talk to us about this, we have a legend again, Professor Khurshid Mohammed. He was coordinating and formulating the Canadian guidelines for preterm neuroprotection. He will be talking to us on this. So some of us who have been attending some other forums like the brain series, the two brain series, the various centers from Canada have already heard his lectures. So now he will be talking to us about neuroprotection preterm infants. Professor Khurshid Mohammed from University of Calgary, Canada, on 23rd December at 7:30 p.m. Indian time. Until then, big thank you and from all of us here in the team, learn from the legends. Until we meet again. Thank you so much.
Thank you.
Thank you, ma'am.